When steroid injections no longer work, another option would be viscosupplementation, which is a lubricant type injection that we actually inject into the knees in a series of 5 shots. If all of these measures fail, then the other option would be a total knee replacement. There have been many advances in total knee replacement over the last few years. Now we can actually give you a custom knee, whereas previously a surgeon had to rely on standard tools that were made for a one-size-fits-all type of procedure. Nowadays we can actually take an MRI of your knee, look at your body anatomy and your alignment from your hip, knee to your ankle joint, and send that MRI to a manufacturer where they actually manufacture custom jigs that allow us to map your knee and place the implant accordingly to your anatomy. We are hoping that this will actually increase the longevity of total knee replacements past the current expected outcome of about 15 years. So basically, once we get the MRI out to the manufacturer, we receive models of the knee. In addition to the model of the knee, we receive these jigs. These are the custom jigs that are made accordingly to the patient's knee. So these fit on the patient's knee during the surgery and fit on the arthritic spurs and all, and allow us to make our markings and our drill holes accordingly. So when we make our cuts, these cuts are being made and adjusted towards your anatomic alignment. So this is for the femur, and this is for the tibia. So you have one for either side of the bone. Femur and tibia look like this. And you flex and extend the knee. Once we make our appropriate drill holes here, that allows us to make our cuts regarding the knee replacement and then put in the implant. The total knee implant is basically constructed of stainless steel as well as a polyethylene implant. This allows you to have adequate glide with flexion and extension of the joint. Whereas before you were having bone fragment or eroded bone, rubbing on eroded bone, creating pain, now you have a fluid motion resembling that of a normal knee. Now if, say, one side of the knee is involved, let's say the medial side of the knee is involved and only this side is arthritic, there are other options. In older patients, one option is to resurface or just replace part of the knee, and this is called a partial or a unicompartmental arthroplasty, and this is what that looks like. You keep your kneecap cartilage, you keep the cartilage on the outside of the knee, and then on the inside of the knee you replace this with a mobile bearing implant. And this is the polyethylene here that allows it to glide and slide. And this can significantly help the patient's pain and allow them to get back to regular activities. But you only can do this in a patient that has isolated arthritis on the medial side of the knee. Now prior to this, if you have a patient that has isolated arthritis in one particular area, and it's not on both sides of the bone, it's only on one side and not on both sides. So this side is normal, this side is normal, this side is normal, and this side is arthritic, or there's no cartilage. There are a number of options for treating this, depending on the patient's age, activity level, and expectation. One option is called microfracture, where we drill small holes into this lesion and allow it to scab over, creating a scab, and heal up, which creates it creates hyaline-like cartilage, meaning it's like cartilage, but it's not cartilage, but allows you to have some sort of lining resembling cartilage to patch up that area. Now you can usually do this in small lesions. Now if you have a lesion that's greater than about 2 centimeters, these microfracture techniques do not work. And if that's the case, this is when we actually do something called autologous chondrocyte implantation, where we take a biopsy of cartilage from outside of this area of the joint where it's not outside the weight-bearing portion of the knee, and we send it off to a lab. We can also take it from over here. We send it off to a lab where they replicate cartilage cells for us, and we go back for a second procedure, and we implant those cells in this defect. That allows this defect to fill in with what appears like cartilage, gives you the support, and actually addresses some of the pain associated with that lesion. Usually this is more for our 2 centimeter lesions in young patients. So there are many options regarding cartilage resurfacing and cartilage implantation. The third option, which I'll mention as well, is called the OATS implantation, which is the osteochondral autograft transplant system, where we actually take plugs from a non-weight-bearing portion of the knee, which is out here on this outside region where you're not putting weight when you walk. So if you walk, you're walking like this. This is outside of that area. And we take those plugs and we plug them into the area that you're putting weight on. Once again, it has to be a small lesion, and it has to be in an area where the other side is pristine without any cartilage loss at all. But there are options regarding arthritis, regarding cartilage loss, no matter what the age. So as I've said before, if you're suffering any symptoms such as knee swelling, knee pain, locking or instability, or have had chronic pain for many years, or even noticed a deformity in your knee, I would recommend evaluation by an orthopedic specialist. And if you're interested in cartilage implantation or chondrocyte implantation in some of these procedures, then I would recommend a sports medicine specialist who has experience in doing these procedures. Thank you.